At this time, I would like to introduce our next speaker, Dr. Kathy Craven. She is a University Health Network and University of Toronto Cope Family Chair in Spinal Cord Injury, Health Systems Innovation, Professor in the Department of Medicine at the University of Toronto, Medical Director of the Spinal Cord Rehabilitation Program, and Senior Scientist at Kite Research Institute within University Health Network. Dr. Craven is a Fellow of the Canadian Academy of Health Sciences and a Fellow of American Spinal Injury Association. Dr. Craven's clinical and research expertise in health services and medical rehabilitation after spinal cord injury. She chairs the Canadian SCI Rehabilitation Association. Dr. Craven is the quality lead for the Ontario SCI Implementation and Evaluation Quality Care Consortium, implementing indicators of quality care across Canada. She is also a co-primary investigator for the CAN SCIP health guidelines, and Dr. Craven's research redefines patients' experiences with common health conditions that come after a spinal cord injury, helping them avoid or better manage heart disease, diabetes, pressure injury, and fracture. Dr. Craven leads UHN's Pride in Patient Engagement and Research Initiative, and she has published over 200 articles on related topics and obtained about 38 million Canadian dollars in research funding as a primary investigator. A round of applause for Dr. Craven.
Well, good afternoon, and I'm sure I'm not going to top our prior presenter, but I do want to acknowledge how brave it is to share one story. I want to say thank you to Kathy and the CPIAP for the invitation to present today. I know a lot about spinal cord injury rehab, and I'm learning more and more about wound care, and I'm sure I still have lots to learn from the people in the room today. And I did want to share some interesting things over the course of the afternoon. I really wanted to highlight the frequency and costs of non-healing pressure injury in patients with spinal cord injury or disease. I wanted to highlight the value of daily head-to-toe skin checks, which we're going to talk a little bit more about. And there are certainly some implementation leaders in the room that you can talk to. I'd like to share with you the projected volume of SCI patients needing flap surgery based on some current data. And I wanted to share my personal clinical hallmark, so no evidence, Craven's opinion, about reasons for emergent escalation of wound closure when we've crossed the line and it really is an emergency. I wanted to review some of the surgical outcomes of flap surgery and discuss some of the challenges and perhaps strategies to address these care gaps. So Chester reviewed some of this morning, and interestingly, we both chose similar references, but in spinal cord injury, there's a lifetime prevalence of spinal cord injury of pressure injury of 85 to 95%. Everyone's going to get one. Hopefully, they're only getting a grade 1. How many people in this room think that pressure injuries are inevitable and there's nothing we can do to prevent them? How many people think pressure injuries are a never event that we can get on top of and prevent? Okay, and some undecided in the room, which is interesting. About 40% of patients, if you look across North America in rehab, have a pressure injury. And we know that the direct costs of treating a pressure injury are cheaper in the community than in the hospital by about $5,000. And that when somebody leaves rehab with a pressure injury, that costs us anywhere from $60,000 to $90,000 a year. And I wanted to share with you some information from the Spinal Cord Injury Implementation and Evaluation Quality Care Consortium. This is a group of 13 centers across Canada that is working to provide optimal and equitable rehab services for all Canadians, regardless of where they live, to help ensure the functional recovery, health, and well-being for individuals living with spinal cord injury. And if you want to learn more about us, we have a number of operational values, but I thought providing some examples based on Chester's discussion this morning might be helpful. So we spend a lot of time in the consortium implementing best practices, collecting indicators of quality care, measuring and evaluating our performance, and working to ensure practice sustainability. So it's easy to make a new practice change, but it's really hard to keep doing it over and over again. And I'm sure many of you have experienced this just around wound care risk assessment, around looking at wounds and measuring them. Everybody gets really excited with a new initiative, but it's really hard to sustain it over time. In the consortium, we look at many different domains of care, but I just wanted to talk today just about pressure injury. And people in the room who are part of the consortium, you raise your hand. Heather, Carol, others. Please approach them, talk to them about this work. When we started and we looked across Canada, we noticed that there was really a lack of accurate skin check documentation and really poor documentation of the teaching provided to patients about how to manage their wound care. So we had lovely recent example of someone who's really learned, adopted it, and taken it forward. And that's what we want to happen in rehab. So the patient learns and has a safe space to practice the skill before they go out in the community and have to do it for the balance of their lifetime. And our goal was really to reduce the incidence and severity of pressure injuries amongst people with spinal cord injury during rehab. Over the last 4 years, we've done a lot of work. We've implemented daily head-to-toe skin checks for inpatients. We're going to talk more about that. We've supported documentation of patient education and the transfer of responsibility for daily skin checks from the patient, from the nurse to the patient or the nurse to the family caregiver. And so that people have an opportunity to practice that skill in rehab before being discharged. And we've worked to really develop some new inclusive patient education resources. So thinking about skin tones, languages, the majority of patients who come here to University Health Network for spinal cord rehab, English is not their first language. So we put out a lot of different materials in different languages just around really basic things around skincare, which you can find on Spinal Cord Essentials for anybody who's looking for more spinal cord injury specific information. That's a really great resource. So one of the things that we talked about doing was doing a daily head to toe skin check where the patient does it with their provider. They're typically their nurse, where we actually, pull the clothing off, pull the dressing off, and have a look at, the occiput, the ear, the scapula. We look at the ischia, the sacrum, greater trochanter, the knees, the medial condyles at the heels and ankle. And we did work, the staff in the consortium who were responsible for implementing these daily head-to-toe skin checks actually created a video for patients. It's available on the Core Tree website, which is educational website created by Spinal Cord Injury Ontario. And we've shown that patients, you can take out your cell phone, connect it to a selfie stick, and you can actually do your own daily head-to-toe skin check. Years ago, we used to use a gooseneck mirror, but that's kind of gone out of vogue. A cell phone's much more readily available. So this is a big part of what is happening in spinal cord programs across the country. With the success of the consortium and loss of the keyboard, I don't know what's happened here. Can I get you to forward it? No, it's not doing that. No, I want to go to this one. Yeah, okay. Okay, thank you. So when we look at daily head-to-toe skin checks, we have now gotten to the point after 3 years of implementation that at our site, 85% of patients are getting at least one daily head-to-toe skin check. And there's a small number of patients who are still not quite meeting that target. 85% I'm really proud of, but our target is 100%. So we still have room to improve and sustain, but we've seen really dramatic changes in the healthcare system with the implementation of these head-to-toe skin checks. The frequency of pressure injury, when we look at who had a pressure injury in the calendar year, January to December 2023, 32% of patients had a pressure injury. And Heather referred to this earlier, but we have data that we looked at in the province of Ontario, which is in one of our publications, but I'm showing you here our UHN data because I couldn't get permission from all my colleagues on time for this presentation. But what we've seen some really concerning trends here. So the light blue line here is the prevalence of pressure injury. So this is people who are getting a pressure injury in acute care. They're arriving to rehab with a sacral pressure sore. And the purple line at the bottom here, which is going down over time, shows that the number of pressure injuries in rehab is actually going down. but the incidence in acute care prior to rehab arrival is going up. And we actually did a much deeper dive on this data, and we showed that patients with spinal cord injury who were in a tertiary spine center were repatriated to the community. This is where they typically got their pressure sore, and then they came to rehab. So it's very important, if you have the ability, if you're working in the acute care setting, to help those patients stay in the model system, which is to go from the tertiary spine center to the tertiary rehab center. That's really what we want to do. And if they're having to go back to their community, that we advocate for them to have the right surface. I've been thinking a lot about crazy ideas to suggest to you guys today. One of mine is, why couldn't a patient be issued a surface in the ER? And that surface follow them for their whole healthcare journey. Like if you're in Alberta Health Services, why does it have to change? Like as you move from building to building, why couldn't the patient and their surface go together? Because every time there's a change or transition from unit to unit, we have the opportunity to get it wrong. And so, and oftentimes people move and you come to rehab, for instance, and it takes us a day to get you the surface you want, but that's a day of missed opportunity. And I say this, you know, as a rehab administrator who'd like to see a system be a little bit more seamless, but something for us to think about. Could we provide a surface in the ER and have the surface follow the patient and then recirculate them through the whole system? So that's an opportunity for some of the bigger organizations around to try to think about that over time. When we look at prevalent pressure injuries, so those at rehab admission, you can see that the number of people with sacral pressure sores is, the number of people with pressure sores is going up. Many have one pressure sore, so 37 patients, but there are many who have 2, 3, 4, 5 or more. So this is not just people on the spine board. This is not getting adequate pressure relief throughout their journey, not getting that appropriate pressure relieving surface and the Q2 hour turning. And I think this are deliverables that we can accomplish. When we look at the location of prevalent pressure injuries, most of them now are sacral. There's a small number on the foot and ischia that we're seeing, but predominantly sacral pressure injuries, which is from lying supine. When we look at incident pressure injuries, so those that develop during rehabilitation, they have a very similar distribution. So this is one of the areas where patients are vulnerable, and certainly for the people who are polytrauma victims, they may have deep tissue pressure injury making their way out, overlying the sacrum in particular, where there's a big bony prominence. But when we look at the distribution of incident pressure injuries, so those occurring in rehab, most of the ones, thank goodness, are stage 1 and stage 2. But when we look at the worst stage, if you look at the stage 3, stage 4, and deep tissue pressure injury, there's still a substantial number. So that's the light blue and the purple columns here. If you look at pressure injury at discharge, with the advent of daily skin checks and routine checking and monitoring of patients, we've actually seen a reduction in the number of people going home with open wounds. It's a small percent, 4%. So a win, but not a big enough win. So we are seeing reductions in pressure injury incidents in rehab. The ones in rehab are more stage 2 than stage 3 or 4. And people are going home with intact skin with just doing daily head to toe skin checks, being able to see what's actually going on. When we first did this, there was some question about, were the nurses just checking the box or were they actually getting in there and doing the work? We did a little bit of best practice implementation around getting there and doing the work. And now we're very confident in the data that we're getting that this is what's actually happening. But if you look across the worst stage of both prevalent and incident pressure injuries at our site alone, so we have 383 admissions per year. If you just look at the stage 3 and stage 4 pressure ulcer gang, that's about 6%. But if you look at the stage 3, stage 4 unstageable and deep tissue, 14%. 14% of admissions are going to need care after they leave rehab. And 14% of people were downloading the costs of the pressure injury acquired in acute care to the rehab sector. So this is not a win. And when we look at the prevalence of pressure injury prior to rehab by year, in the years that we've had the consortium we formed in January 2019, you can see that the sacral pressure injuries are really on the rise. So very concerning. And if we look at incident pressure injuries, there is a trend towards a rise in the foot and ankle injuries in rehab. And something for us to really pause and reflect about. And this may in part reflect the changing demographic of spinal cord injury, seeing more people with non-traumatic spinal cord injury who are older and have comorbid vascular disease, which may be a contributor to what's happening. And we have written about this work and how the changing prevalence of pressure injury is really scary in Ontario, and have made a public plea for us to work upstream. So we need everyone making sure our spinal cord injury patients get the right surface at the right time and throughout their care journey. And we really think there's a value in implementing that head to toe skin check, maybe not every day, but perhaps every shift. Think about that. I know there's a lot of nurses in the room are probably panicking. But this is really important. You know, that actual visual inspection makes such a difference. And I think really have a time to talk about time is tissue. If you're in the ER and you saw a patient and you missed a heart attack, would the physician and the nursing team feel horrible? Yes, does it go home with them? Does it haunt them? Every spinal cord patient that goes to the ER comes back and tells me they got a new pressure sore while they were in the ER. We need to raise this time is tissue paradigm to the same level as heart attack or stroke in the ER. It should be, you have a spinal cord injury, you arrive, here's your surface, even if you're waiting. So if you have your own wheelchair and you can wait in your wheelchair and you're well enough, that's fine. But if you're unwell and need to be put on a horizontal surface, then we really need to make sure we're giving people the right surface right then. I wanted to talk about bed rest, and I know I am preaching to the converted, but I really wanted people to think about this. We have patients who, when they're on bed rest, they get constipated, they get respiratory insufficiency. Now they need volume augmentation and or a cough assist. They get depressed. I mean, they actually have clinical depression. And it's only the toughest people cognitively who get through without getting depressed. Many of them have inadequate nutrition because it's hard to eat when you're lying down. They develop contracture, and many of them have cellulitis or osteomyelitis. How many have seen patients who've had cellulitis or osteomyelitis more than once? More than 3 times. And so I think they also get the baroreceptor dysfunction, they get orthostatic hypotension, and they get cachexia where they're just, all their muscles just being atrophied away, and you can see them wasting in front of you. And I think we get a little bit conditioned to accept this. And what I want you to come away with from today are Craven's rules. When you have these people that are in this cascade of secondary complications that stem from their pressure injury, that you recognize, when do we stop it? When do we escalate it? When do we call this an emergency? So these are Craven's rules, and this is from my 25 years of outpatient practice, but not from evidence. When a patient's CRP is over 100, this is an independent risk factor for all-cause mortality across the general population, but it's even higher in the spinal cord injury population. So anyone with a CRP of 100, you need to recognize this as a medical emergency and get them there. We know in spinal cord injury patients, when they have the very, very high CRPs, they also have the hemoglobin in their boots. These are the people you've already tried to get an iron infusion or a blood transfusion for them. And their albumin levels are really low, and they can't hold any fluid in the wound or near the wound bed for love or money because it just leaks out. And those are the wounds that are just leaking, and you're just packing them. And when we look at them, they're the ones who've had a cytokine storm. If we look at their blood levels, they are crazy. So I want you to recognize the patient with a CRP over 100 as a disaster looking for a place to happen and really needs to be escalated. And then my other one is cachexia. When you see the patient who's had weight loss, they have, increased mortality. And usually that weight loss is the cytokines from the wound. And when the patient reaches a refractory stage, where this is where you're actually supplementing them 4, 5, 6, 8 times normal, and they're not maintaining their weight. This is usually when the person has less than 3 months to live if we don't intervene. How many people have seen a spinal cord patient wasting away and recognize this as a disaster? How many people make the effort to weigh people every time they come And just to understand, because you'll see the patient, you'll see them wasting away, they're losing their muscle, but they get this lovely grayish discoloration. And when you're seeing this, it's, cachexia that's not responding to appropriate intervention where you're confident the patient's getting the intervention. This is another time to pull the ripcord and say, this is an emergency. And these are the people that I actually, if they come to my clinic, I call the ambulance and I send them to the ER in the ambulance to try to indicate the urgency. And I place the call to my colleagues in acute care, in infectious disease and in plastic surgery, and try to escalate the crisis. So there's lots of times patients have recurrent osteomyelitis and they're grumbling away, but they don't have cachexia, they don't have a CRP of 100. It's okay to persist. But when you get to these 2 mile markers, I would say it's time to escalate it as an emergency and make sure people get seen. Flap reconstruction is our panacea, right? It's going to help everybody. What I would like to say to you is there are some really beautiful rehab therapies, including electrical stimulation therapy that Pamela Houghton and the group in London have really promoted, that actually change the chemistry of the wound bed and promote wound healing. It's a Canadian best practice, developed here, not implemented here. We need to get it together and put our Canadian evidence into practice. We also have the opportunity to use ultrasound for healing deep tissue injury, proximal to bone below the tissue surfaces that I don't think we've really taken advantage of. And in those patients who really do have a non-healing wound, we do want to refer them on for surgery. But remember that when they have surgery, they've used their tissue and they're at risk for wound breakdown. So you've got to be really careful in your selection of candidates. They will actually follow the instructions, because otherwise they're just coming back with a new wound and a greater tissue deficit. And our surgeons provide life-saving care, and they will willingly do it. There are many, many plastic surgeons, very well trained and able to do these reconstruction, but complication rates are between 30 and 50%. So, and the complications depend on the tissue selected and which type of flap you actually have, which I won't bore you with too much. But the hospital costs of surgical closure for a stage 4 wound are about somewhere between $12,000 and $7,000. But we know that those who have a longer length of stay, who are women, who are discharged anywhere else other than a rehab setting, have bladder incontinence or a myocutaneous flap. Those are the ones who are at the greatest risk for the early perioperative complications. And, everyone is at that risk of wound dehiscence, bleeding, infection, hematoma, a little bit of necrosis. And the complication rates, depending on the hands of the surgical team and the team monitoring them, vary between 10 to 60%. So there's still lots of room to refine our surgical processes for these patients. My personal experience is that the patients who have much more tissue transferred are more likely to have the hematoma. When they're trying to fill a bigger spot with tissue, are more likely to get hematoma or a little bit of regional necrosis if they have active infection at the time of the surgery. So just food for thought. This is work that was published by Laura Teague, who I know is a friend and colleague of many of you. But I think it's really important to just visit this. The average spinal cord patient that goes for flap surgery has had their wound for how many years? 4. We can do better at calling a wound that is not healing. I think all of us know in our gut, when we get to 12 months and the wound is not moving, we need to call it. We need to try some of those last ditch efforts. But then we really need to be referring people earlier. People should not have to wait 4 years. When we do the look back year, that year before surgery is an expensive year, costs about $42,000. In the first year after surgery, about $80,000. But the costs stay high for the second and third year while we continue to monitor them and make sure their skin doesn't break down. But the difference in people, if you see them come back when they're done, it's transformative. There's a client I just saw a couple of days ago, last week, who we sent to Sunnybrook. I thought it was going to be the end of him. He got 4 surgeries from Dr. Rogerson Wallace. He had a really great tour at Bickle in our complex continuing care unit and then came to rehab, then went home, and he's got a whole new lease on life. So really transformative. Several years ago, we developed sort of a skin flap process map and had pilot money from the ministry to look at having patients go for surgical consult, working through the rehab team to address their medical instability before surgery, having them go to BICL or CCC for postoperative care. And then once their sutures are out, their skin is intact, they can have full hip flexion, getting them to come to rehab and address their unmet rehab needs. I have kind of broken this down into some simpler slides for you that, this is a simple protocol. I think it could be done in CCC just as well as in the community if there was a really great nurse. I mean, one of the things I think in community nursing we really need to work on, and this organization should advocate for, is that there's risk stratified care. The most highly skilled people are seeing the people with the most serious wound, and that the novice person is seeing the person with the minor burn or small wound that is going to heal. So I think there's an opportunity to really do some risk stratified care and making sure the most talented nursing team is seeing the patients with the most complex wounds. So in that early first couple of weeks, it's a very hard time for patients. They have to remain in bed. There's no sitting. They need to do a bed bow routine. Often the physiatrist will do Botox if the patient has spasticity that's threatening the incision. And we need to make sure they're getting VTE prophylaxis. The surgery and usually the premorbid infection has got their HS-CRP very high, and they're very high likely to get DVT or PE. And we really restrict their hip flexion to less than 30 degrees to try and give the skin a chance to heal. And then they need help, usually with bathing, dressing, turning, because they can't really get up. And then we're trying to feed them high levels of protein, as well as a bit of an anti-inflammatory diet to try to reduce their C-reactive protein. And then as time progresses, we start to do those daily skin checks. We start doing the bowel program in bed and work at infection control and look at their mattress and other surfaces. In week 3, we're looking at suture and staple removal, looking at the surgical wound integrity. We start to gradually increase their hip range of motion and progress towards seating in their wheelchair. We go through transfer training. Usually people have to relearn transfers because they have old bad habits. Like I used to graze my buttocks over my wheel rims, or I was doing, a Roger Dodger, rolling transfer. So we have to reteach them how to do transfers, which person has to be willing to do. And for somebody who's had a spinal cord injury for 30 years, it's actually really hard. If you learn to ride a bike one way and you're being asked to do it some other way, it's hard. And then doing some discharge planning, looking at, does the person have unmet rehab goals? Do they have community goals? Are they returning to parenting, work, all these other things? And then trying to put some plans in place for them. At week 4, usually we've begun that full gentle hip range of motion, less than 90 degrees, but we're just starting to do that regular. We've got the PT involved in their care, doing some upper extremity strengthening and trying to address their global deconditioning. They're working now on being able to do some transfers. We make sure that they're competent in their skin checks. They're doing seating and wheelchair prescription. Sometimes they need a whole new seating system. After surgery, it says where things hang and where they don't, and how their pelvic floors change is sometimes quite different. And also the amount of tissue in the posterior thigh is often quite different. And the redistribution of weight between the ischias is often altered. And then we start to begin some graded seating. And week 5, some further mobilization with the goal in week 6 that if it's appropriate, they would come to rehab for activation, or if they are appropriate, they could go home with family supports depending on the setting. So I was asked to comment on to what are some of the conundrums. We have good funding for surgery and surgical consult. We have great funding for physiatrists to see patients. And we really have nursing care throughout the patient's journey. We don't always have the same nurse. So if I had my wish, it would be you have continuity of nursing care throughout a patient's journey. But the pieces that we don't have funding for, which are so mission critical, are that graded return to seating and the seating assessment and the functional restoration so that we get the person back to their pre-morbid activities. And so we need to think about rehab, for instance, as a two-way street. It's not just to come through and get out into the community, but if you have new complications that perhaps you could revisit and access functional restoration. And I think we need to think a little bit more creatively about how can we provide, a mobile seating assessment and, more community-based functional restoration for the people in their home. Because when you've just recovered from flap surgery, you really can't travel to the center, even if you live in the region. Where can you go in Toronto that doesn't take at least half an hour? I mean, maybe if you live in North Beaver Breath, you can get to the rehab center in 17 minutes in Thunder Bay or something, but it's really not feasible for people when they're recovering from flap surgery to get in the car and come to a setting. And the other thing we've seen recently that Carol and I have really struggled with is patients are being charged the cost of an ambulance transfer to come to the hospital for an assessment. If you live 75 kilometers away, it's like $1,500 bucks. Would you want to spend that on an ambulance? So we need to really push ourselves to think about how can we do virtual care or virtual care with a colleague or a nurse that's been responsible for the patient's care throughout the journey at the bedside. So we need to think a bit more creatively about how we can provide those other components of the care. But the seating reassessment, new pressure mapping, new seating system is usually an integral part of the flap surgery. And it's the piece that's not funded, nor is the reactivation. And so I think we need to think creatively about how we bundle these things as services. So it's not just the surgery, but we know it's the surgery with all of these things. So in our pilot project, when we did all of these things, patients went to Bickle, then they came back to Lyndhurst for rehab. They got a full new seating assessment. They went home. We were able to reduce our complication rate to 20% from 50 with the same surgeon all the way through, but adding up these back end things. So I think we need to start talking about a pathway of care for flap surgeons, not an isolated episode of care, but a pathway of care that has integrated pieces in the pathway. And so I drew up Craven's optimal paradigm for care, which is shared care between the community, rehab and CCC, and acute care that I really think is important for us to think about. So these are the patients that challenge us to do systems thinking, not care episode thinking. And systems thinking is a bit of a different process, but really requires all of us, as Sharon said, to work together. I hope you'll stay connected and learn more about the Spinal Cord Injury Consortium. Heather Flatt, our advanced practice leader, and Carol are here in the room who did the bulk of the work to get daily head to toe skin checks in place. But I would like you to think about, what would a world look like with daily head to toe skin checks in acute care? Giving patients one surface and it went with them through the whole journey of care. Or thinking about selling a health authority or the Ministry of Health a pathway of care, not an episode of care for patients who need surgical intervention. And you've heard these are long journeys for people. Can you imagine you're going to spend 4 years waiting for surgery? You finally get surgical consult, you go for surgery. Now you need another months of care and then a graded return. So from the start of your grade 4 pressure injury to return to your functional mobility, if you're lucky enough to have a wound that can be closed, is 5 years. Think about that. The cost to people and their quality of life is just ridiculous. So I think we can do a better job about calling those non-healing wounds and escalating the people who need care sooner and recognizing those who are in an emergency. So CRP over 100, cachexia not responding, those are the people we need to actually activate the resources in acute care. No more community management. This is an emergency. Thank you.
Thanks, Dr. Craven. Now we're going to open the floor for questions.
I love the daily skin checks. In some areas of our centers, it's supposed to be Q shift, head to toe. We do know that's not always happening. I was wondering if there's any inclusion of skin tone ranges in that skin check, because we know most of us in our healthcare education, we don't learn about how to assess dark skin tones as effectively. So I was wondering if that was included in the skin assessment.
Certainly, that's part of our nursing education and ongoing discussion. We've created resources for patients and families. And I know Carol, when she's at the bedside, is on everybody, talking to them about it, and helping us to recognize with the different skin tones what we're actually seeing and recording. So it's not formalized, but it is part of what we do. Carol, did you want to add anything?
I just wanted to let you know that thank you. Just wanted to let you know that we have been using a resource from Hillrom. They have the Monk skin tones, and we found that's very beneficial. We started using it when we did our surveillance, and it takes a little while to figure out the different numbers, but it was very beneficial, and we're using that.
I guess I have a question. Thank you so much for your presentation. Very valuable. I have a question about sitting clinics. How many sitting clinics are we currently having access to for the outpatient clientele? And do we have access to pressure mapping? I've been witnessing reduction of funds everywhere.
If you go to a tertiary spinal cord injury rehab center, there are 6 in Ontario, all of them have a seating clinic and pressure mapping. But one of the dramas in Ontario, I don't know if it's true in other provinces, is that during COVID, a lot of the community-based assessments and vendor-based assessment centers have just gone the way of the dodo. So it's putting a lot of extra burden on the tertiary seating clinics, which is really problematic. And I know you asked a question about references related to spinal cord injury. I just wanted to share that we do have the CAN-SKIP guidelines. So if you Google CAN-SKIP and KITE, this is an integrated guideline of 43 different spinal cord injury specific guidelines that are merged into one. You can enter the patient's neurologic level, and it will give you the guidelines for wheelchair seating, for their bladder management, for their skin, those kinds of things. So if you're interested at all, CAN-SKIP and KITE in Google will get you to the website. I'm sorry, I meant to put up a QR code. Sorry, your question about seating. So seating is so important. We've identified in the consortium that the number of OTs with specialty seating certification is really not sufficient. And we're putting a lot of, kudos and a lot of responsibility into a small number of OTs that if they choose to retire, we're really going to be stuck. So we've been working through the consortium to try to increase the education and training related to seating and get people familiarized with the WHO wheelchair prescription process, and trying to promote people doing training. In the consortium 2 years ago, we had 93 OTs from across the country do wheelchair skills training, just to upskill people around how to do the wheelchair skills test and some of the performance elements that Lee Kirby and Dalhousie has been promoting. So lots of things around wheelchairs and wheelchair prescription. One of our biggest challenges in spinal cord injury right now, frankly, is we have all these people who are motor incomplete and that we're not sure if they're going to recover all the way to walk. And so sometimes that seating process is delayed while we try to figure out, who's going to be a wheeler and who's going to be a walker. But for those who are motor complete and we know they're going to be wheelers, we should be moving through with wheelchair prescription in a timely manner. Sorry.
Hi, I'm Stephanie from Hamilton Health Sciences. I remember a patient about 10 years ago who ended up needing 3 flaps because he was, underhoused or homeless or whatever phrase you want to use, and he could not afford the copay to get a tilting wheelchair. So he just kept going back he'd have his flap surgery, he'd do well, he'd be in hospital, he'd go back into the exact same chair, get the same wound. So has that improved in terms of resources for those that can't if the ADP covers X and they can't come up with the other portion, what are the resources?
Yeah, so the two things I'm aware of in Ontario is you can approach Spinal Cord Injury Ontario and they will help try to fund that person for that one piece of equipment that they are really struggling with. We would consider that under candidate selection. If you know the person's not going to be adherent, I would not be selecting them out for surgery because they're just going to have more complications, more tissue deficit. And, it's already 50% that are going to have a problem. And you want the person who's going to work hard and try to reduce it down to that 20%. So I think this is part of the rehab and, knowing the person and the surgeon's sort of job to sort of filter those people in and out who are able to adhere. Because it is super expensive, as you can see.
Dr. Craven, I just want to ask a question in terms of your data that you provided earlier regarding the incidence of patients developing pressure injuries from acute care being admitted to rehab. Was there any further stratification done in terms of where in acute care setting that they have developed this, or did it start in the ED or any sector of the acute care setting?
So we can't really tell. So we used NRS data and rehab intakes to identify, did the person come directly from the spine center or from a regional hospital? So we would know that the person had, say, spine surgery at St. Mike's and then was repatriated to a community hospital and then came to Lyndhurst, but we couldn't necessarily identify where the pressure injury started. So we had to use the available data within the consortium. We're a approved QI project, and so we're sort of limited to the data that the rehab site owns. So some opportunities maybe to do linkage with ICES and others in the future to look at that in more detail. When we did that project, we came up with so many more questions than answers, but really allowed us to ring the alarm bell of, hey, this just can't keep happening, because the costs of taking care of these patients are being downloaded to the rehab sector. And there's more people with wounds, and we're not going to have enough people to do the other aspects of rehab, which are so critical to the patient.
Are there any other questions?
Heather, did you want to provide any other commentary about implementing head-to-toe skin checks?
What was happening.
Yeah.
So that, I think that's the caveat as well, recognizing it. Sorry.
It was a great thought.
Everyone hear what I said?
It's just for the people online, Heather, so they can hear you.
Sorry. I think it's the caveat is around, it was the documentation of daily head to toe and shift to shift documentation of that skin check. And it was also the piece for us in rehab was passing it on to the patient. So a patient who the nurses were thoroughly checking that patient's skin, but then they were becoming independent in preparation for going home. So they were managing their own bowel and bladder, but needing to ensure that we were handing over and ensuring the patient was doing their daily head to toe skin check. And that was a big gap for us. It was that patient who was not going to have care in the community, and they needed to be fully able to do that themselves. And that's where I think we really tried to improve, ensuring that documentation and ensuring the patient was checking and the nurse was aware that that patient had done it and that it was getting documented.
Thanks, Heather. It's important clarification. Yeah, there's lots of things the nurses we think we're doing, but maybe not writing down. Now they're writing it down as well, and also documenting when they've collected from the patient that they take the head to toe skin check. So thank you.
So Dr. Craven, on behalf of CBIAP, thank you very much for such an excellent presentation. Thank you for reminding us about the value of inspection regularly and sometimes even more frequently than daily, and also for creating a preventative care plan that starts at the get-go. And sometimes I find as clinicians, we're so fixated with a number of times how often we should be repositioning patients to Q2 hours, but at the end of the day, it should be based on the level of risk of an individual that allows us to define how frequent and what types of preventative offloading surfaces or devices or modalities that we should consider along the way. So thank you so much. At this time, it is presently 2:07, and we will give people a bio break and also some carrot breaks as well for coffee. And please engage as well with our industry and exhibitors today. We will reconvene somewhere around close to 2:25 this afternoon for our discussion forum. Thank you.
Good.